So Dana's done an excellent job going through the drugs that are available. So I'm going to focus a little bit more on how do we strategically utilize the drugs that we have, and how do we place it in the context of routine patient management. By the way, I'll just here are our disclosures. So we've heard that we have a number of options, and typically we've approached the disease in terms of castration-resistant disease, in terms of there we go. In terms of docetaxel as the sort of first-line standard chemotherapy. And as you saw, the development has previously been focused on the pre-chemotherapy space or the post-chemotherapy space. Radium-223 is the first drug that actually has an approval across the disease states, and pembrolizumab, you heard about, is now potentially active in patients who we hope to be able to identify a priori, who have either MSI or MSI-high tumors, or a major area of focus is other predictive markers in tumor that could help identify those patients a priori. Now we're starting to move away from this classification, and the real focus now is how do we deploy these drugs now that we have 6 approved drugs and 1 with a breakthrough designation in terms of maximizing the individual patient benefit. I started here when CT scans were first available in the pre-PSA era, and essentially we really did not have a meaningful way to accurately assess disease. So the real focus is how do we develop drugs with a disease that doesn't really behave like other tumors, where the predominant site of metastasis is bone. So the first thing we considered is the states classification. And as I mentioned earlier, in the castration-resistant state, you had the non-metastatic patient population, first-line chemotherapy and post-chemotherapy. And early on, the focus was delaying chemotherapy as long as possible. But if we actually think about it, when you're seeing a patient, what you really need to consider is what has been the past history of the patient relative to what is actually going on at present in order to figure out what to do in the future. For example, if you have a patient whose disease has spanned a course of 20 years and now he's castration-resistant, likely his outcome is going to be very different than someone who reaches castration-resistant in 11 months. So we consider each encounter as a new one, and we're focusing now on what is the objective of treatment for an individual patient. Some patients are worried about their PSA, other patients are more concerned about bone pain and could care less about their PSA as long as you treat the bone disease. So when we're starting to think about how do we approach a patient, we think about the disease at diagnosis, high grade, was it regionally metastatic? What are the prior treatments that the patient has received? We are learning that cancer is not much different than infectious disease, and with the ability to characterize disease in blood, we're able to pick up some of the changes that we have learned will be associated with resistance in the laboratory very, very early, which poses a real conflict, because just because you find a V7, AR-V7, doesn't necessarily mean that it is clinically active or that you have to do something about it. So we think about with the patient, what is that patient's prognosis? That will give a sense of urgency as to whether or not they need treatment. Again, if they're significant, need to do something. And in terms of prediction, we're trying to figure out what is the treatment that's going to give the greatest benefit to the patient. So as a prostate cancer community, we organized what we call our working groups to try to decide how we're going to approach the disease. And in terms of response, since we rarely have measurable disease, we had to think in terms of more in terms of what we actually want to do. We can control the disease and stabilize it. We can relieve symptoms. Or, as you have heard, we are now starting to ask the question in some of the earlier disease states, can we in fact eliminate the disease? So we divide things into early measures of response, or what are called time to event measures, and one can think about overall survival as the delay or the prevention of death from cancer. Or, for example, if we have a patient with pain, the first agenda item would be to control that pain and obviously to prevent it from recurring once again. And if you actually look at the drugs that are approved and their indications, it fits perfectly with the control, relieve, delay, prevent paradigm. So the only drugs that are approved for early what we would call response measures radiopharmaceuticals for the relief of bone pain. Mitoxantrone was approved in 1996 for palliation of pain. Alpharadin does not have a formal pain indication, but it is indicated for patients who have symptomatic bone disease. The later events, the bone targeting agents, are approved to prevent skeletal-related events, which can be quite debilitating. In alpharadin, they use significant skeletal events. Abiraterone and enzalutamide also have been shown to delay these events, but they do not have a formal indication for them. And as mentioned now, there are a series of drugs that have been shown to prolong survival. Pembro has not been formally tested in a randomized trial, but based on the molecular profiling is now indicated for patients with that profile. We look carefully in terms of what we would consider more early traditional response measures. There are no approvals based on a PSA decline, no approvals based on a shrinkage of tumor, no approvals based on an approval of bone scan. And I mentioned circulating tumor cells because we have recently completed a series looking at 4,000 patients enrolled in 5 randomized trials and have shown a very strong association with survival with a circulating tumor cell endpoint that is currently under FDA review. So what are some of the principles that we consider when we're either in clinical trials or in practice? We think about each manifestation of the disease separately. For a patient with symptoms, that becomes the primary focus. Patients with visceral disease, a very poor prognosis, that will dominate the patient's survival as opposed to lymph nodes. We have recommended and do not report global measures of response that are used in RESIST. We consider each manifestation separately. And very important is not to stop a drug prematurely when in fact the patient may be benefiting. And one of the, again, real highlights was Michael Morris's group, where he was able to define a bone scan progression measure based on a clinical measure of are there new lesions or not? Very simple. And with that, again, it is now included as a regulatory endpoint. Again, here's some examples. So this is a patient we saw in the outpatient setting, rising PSA, going on treatment, treated with Abiraterone, had a very large rise in PSA, had pain. We opted to confer to, again, as per the guidelines, we repeated the evaluation, did scans, did not show any progression, and as you can see, this patient essentially had stable disease for a period of this thing is really sensitive, for a period of about 3 years. If we only relied on the PSA, had not confirmed that his pain actually was more from golf than from cancer, he would have been denied a very effective treatment for several years. With respect to bone scans, a very simple bone scan progression measure that took a year to validate here. That means to have our nuclear medicine physicians reproducibly record the measure. And this was important because often one will see a worsening of bone scan, which is actually disease flare that represents healing and not necessarily to progression. And this is what we call the 2+2 rule. And you can see here's a baseline scan, multiple bone metastasis, 2 new lesions. Recommend that you confirm that these are in fact new. The third scan does not show additional new lesions. The patient is still on treatment, and only at this point do you start to see additional new lesions. So we would consider the progression at this point and not stop the treatment here. This is now standard in essentially all clinical trials. One could argue if this is meaningful or not, but you actually look at the patients who demonstrated a flare on their first bone scan, 72% did not have the apparent progression confirmed, and these are patients who would have been denied effective treatment. And equally important, if you're developing a drug, the easiest way to show it doesn't work is not to give it. So this is now standard. Now, how do we incorporate treatments in a changing therapeutic landscape? As you've heard, there's now been several molecular profiling efforts, and what we have first tried to do, as recommended in our working group 3, is to identify subsets of patients for whom castration-resistant, for whom there are specific agents that are most appropriate or which might be specifically contraindicated. This does not have to be a molecular parameter. So for example, radium-223 is indicated for patients with symptomatic bone disease independent of what the molecular profile is. And a second agenda item obviously was to develop intermediate endpoints that would enable us to see more quickly that the drugs are either working or they are not. So one of the things that we've learned is that we really don't know how to deploy the drugs optimally in the individual patient. So what we recommend is to essentially record what prior treatment the patient had in the order that they were given. And as you can see, we have eliminated the first-line docetaxel. We think about therapy 1, therapy 2, therapy 3. Why is this important? Because as we start to use the drugs in castration-resistant disease and move the drugs earlier, the castration-resistant disease that we saw on protocol is not going to exist anymore. And the so-called first-line patient may have seen docetaxel, may have already seen abiraterone, and likely this tumor will be biologically different. Again, we've heard from several speakers, Dr. Kantoff earlier on, Dr. Chen, Dr. Rathkoff, about the biologically defined taxonomy of frequent alterations we are seeing now is in the PI3 kinase signaling pathway. The AR alterations still dominate. DNA damage repair slightly less frequent. But again, we are seeing specific protocols for each of these molecular subsets to the point now where we're getting smaller and smaller ends. And in point of fact, with all of the interest in the DNA damage repair pathway, if one looks very, very carefully at the number of protocols that are open for this disease entity, if you will, there's almost more protocol slots than there are patients. So this becomes a real problem if we don't start consolidating our efforts. We also heard earlier about the frequency of germline alterations to the point now where we consider testing of germline testing mandatory for the prostate cancer population. And again, we'll be approaching New York State to get certification of this concept. So the real question now is, can we start to identify the molecular alterations short of doing a biopsy? If one looks at a bone scan, we learned very early on that many of the lesions that we see on the radionuclide bone scan are not active. Many of these are healed lesions, and if one puts a needle in them, one, it's painful. Number two, all you'll get is calcium. You won't get any tumor. And if one looks further at the individual lesions in the patients, we're learning that many of the lesions are very, very heterogeneous. If you just look at the uptake of glucose across tumors, you'll see some lesions that are very low, others that are very high. Typically, we go after the, quote, hotter ones if we can do that safely. But what you'd really like to be able to do is get a sampling of all of these lesions. And we, again, our hypothesis is that if the blood is circulating through different tumor sites, the circulating tumor cell population or the cell-free DNA populations are likely to have mixtures of all that are representative of all of these tumors. So again, here's an example where we're trying to consider how long do we continue a drug. Here's a patient again. He started on treatment, has a very nice drop in PSA. Each of these is approximately 3-month intervals. This is a patient treated with enzalutamide very early on. And you can see his PSA starts to go up. And in the old days, we would say if it went up 50% from baseline, that patient would have progressed. Did that necessarily mean the patient failed to the point where you had to stop treatment? No. And we kept looking on imaging, and finally he ultimately became symptomatic in bone and was treated with radiation. And you can see his PSA dropped to 0, where it's now remained for approximately 9 years. So again, here's an example where typically this patient, yet by criteria of PSA, is progressing, but he didn't necessarily need to stop treatment based on clinical grounds. And we used to classify these patients as the drifters, if you will. Dana Rathkoff did a very interesting study where she was looking serially for the presence of mutations associated with resistance to androgen receptor targeted agents over time. And using an assay that was specific for each of the individual mutations, she was able to show that she could detect these mutations even at the start of treatment at a fairly low frequency. Later on, toward the end, the frequency really didn't change. So here's an example where just because you have a very sensitive molecular assay and you find a mutation that in the laboratory is associated with agonistic or tumor stimulation, again, does not necessarily mean that that you necessarily need to stop treatment. So now what we're starting to see when we identify these molecular features associated with resistance, and we start to see them go increase at a higher frequency, you're starting to see what are called add-on trials, where instead of stopping the initial drug, which may be controlling a significant portion of the disease, to add a second drug to see if you can eliminate the population that is resistant. Again, a very different type of trial design. We're also starting to recognize that the disease can progress in different ways. In some cases, as I showed you earlier, it could just be a PSA rise, which is not necessarily clinically significant. Or one can see a growth of an existing lesion, which potentially could be treated by focal therapy. We showed another example of that, where solitary progression in bone. Or you can see development of new lesions, which we would argue is more clinically significant and very often associated with an increase in circulating tumor cells. But because of this, clearly showing manifestations that would typically be considered as progression, which we may document as a progression event on protocol, does not necessarily mean you have to stop treatment. So we came up with the concept of what we call no longer clinically benefiting, which allows the physician to be a physician even for a patient on protocol or especially on protocol. So you can continue the drug until you determine that the patient is not benefiting from the drug. That may mean the development of pain in multiple lesions, development of new lesions. And again, this was developed in collaboration with the FDA. Their request was record why you decided finally to stop the treatment. Important here, it extends the concept of allowing treatment to continue until it is deemed that it is clinically significant. And as mentioned, it distinguishes the need to document progression for reporting on a protocol with what you would do in clinical practice, and permits the doctor to be a doctor, which I think is very important in this disease because, again, it is really important to apply one's clinical expertise when treating these patients and really determine what the major issue is that is causing symptoms or might indicate a clear worsening of a patient's prognosis. And as mentioned, the FDA has mandated on protocol, make sure that you report the final reason. And here's a very nice example that Dana Rathkoff's trial, where she was looking at two different patient populations and looking at the PSA response in patients who had seen prior to Apalutamide based on prior exposure to Abiraterone. You can see in the untreated population, looks very interesting. Here looks less so, but applying the principle of no longer clinically benefiting, we propose representing an individual patient's course in swim lanes. And you can see when there is a progression event documented. But if you actually look at how long the patients were on treatment, about 40% of the patients were on treatment with this drug for approximately 6 months, 10% for a year. Granted small numbers, but again, this is a relatively easy drug to give, oral therapy, and one would certainly not like to deny patients a drug that they can continue to benefit from simply because of a protocol-specified measure, which does not necessarily represent a significant clinical deterioration in their condition. Now, a major focus of the field is on prediction and how does one do so from blood. And I'll just use a quick example of the ARV7 status, recognizing that there are a number of alterations that can occur in the androgen receptor signaling pathway, including mutations, splice variants, overexpression, intratumoral DHT synthesis, where the cancer becomes its own androgen factory. There's GR upregulation, an area that's starting to receive intense focus now by multiple pharma sponsors. And again, as you heard, there is a complete androgen independence with a very aggressive subtype. And frankly, when you see this genotype in the clinic, you're really stuck because there's really no effective treatment. We heard about the AR splice variants, but essentially what is unique to the AR splice variant is it encodes for a specific protein that can be directly targeted, either be detected by a PCR assay or an antibody to the protein itself. And the way these function, they are postulated to enable activation of androgen receptor signaling in the absence of ligand. And again, schematically, one can look at the ligand binding domain. Think of the N-terminal domain as the accelerator. And here's the first example that was reported by Dr. Antonarakis from Johns Hopkins. And you can see if the ARV7 was detected, this is with a PCR assay. The patients did not respond either to Abiraterone or to Enzalutamide. And they went on to look at the effect of taxanes, and you can see the taxanes really don't care what the ARV7 status is. And the recommendation would be that if you detect ARV7, one should then prescribe a taxane over an androgen receptor signaling inhibitor. Now again, this is considered almost like a phase 1 trial if it were a drug. And of course, this has stimulated its very, very intense interest. And it's being tested in a number of rather large trials, as you can see on the left. But importantly, you can see that there are a range of assays. And when we're reading the literature, what is really critical is to understand that any two assays are not comparable. And each of the assays has to be independently validated for its analytic performance and must be tested in the same way that a drug is from phase 1, phase 2 to phase 3. This is a lot of work. And we've heard a lot about cell-free DNA. It's been around. There's probably billions of dollars that have been spent on it. Right now, there are 2 companion diagnostics that are approved to detect mutations in lung cancer. That is, these are the only FDA tests approved. For me, prostate cancer is not a disease where mutations are frequent. So again, to me, looking for EGFR mutations in the molecular world of liquid biopsies is low-hanging fruit. Again, the genetics of prostate cancer are very, very different. So that doesn't mean that any one of these tests is better than the other. What it means that each one, if it wants to make a claim, has to go through the independent analytical performance, both for its assay performance and clinical testing. So we've been working with a company called Epic Sciences. We were particularly interested in them because there's no selection. You essentially take the Buffy coat blood sample, lyse the red cells, put the Buffy coat on slides. There's a staining procedure, then a scanning procedure which can identify various events. The simplest way to think of this is facial recognition. And this started out essentially look at macro cell types. So here, for example, you would see a traditional cell, circulating tumor cell, cytokeratin positive, cytoplasm, nucleus surrounded by cytoplasm, good morphology. You can start to see small cells. We don't go beyond that because this is a broad range of cells. Some are cytokeratin negative. But if you start getting into a little more detail, you can start to see different different features in the nucleus. Here you're seeing large nucleoli, and it's turning out that each of these is biologically different. Often you can see clusters, which portends a very poor prognosis. So again, this is more of a cytochemistry type interpretation, but one can also use imaging software in a similar fashion. And one of the key features in terms of biomarkers is the concept of clinical utility. It is the one factor that rarely is achieved in trials using various biomarkers. Clinical utility very simply means that through the use of the test, the decision you make will result in benefit to the patient that is superior to that which you would get if you didn't have the test result available. And again, very few tests get that far. So our group essentially decided we would focus on the decision points and draw blood samples and analyze them at the point we were making a decision. The decision was made independent of the result. If one looks at first line, you saw earlier that in the first line setting in patients who haven't had second generation hormones, high response rate, lower in the second and third line. So we focused our efforts on the second line. In this case, instead of using a PCR assay, we used a exon-specific antibody to the ARV7 and essentially did an immunohistochemical assay. We essentially grouped the patients whether they were receiving the first treatment for castration-resistant disease, and you can see the ARV7 frequency is quite low. It starts to go up in the second line. It goes up further in the third line, but note that not every cell is ARV7 positive. If you look summarily, you can see that, again, the frequencies go up and that it's statistically significant. What this tells you is that the AR is not likely to be the whole story because its frequency is lower than the frequency of non-response. But to see if that was meaningful, we looked at 3 measures that would be associated with a benefit. We looked at the time that the patient was on treatment. We looked at radiologist-reviewed radiographic progression-free survival and overall survival. And again, in all cases, the patients who were treated with AR-directed therapy had inferior outcomes when treated if the AR-V7 was present. And again, looking for whether or not there was a superiority of treatment with a taxane, you can see that with the AR-V7 present, a significant reduction in mortality with patients who were treated with taxane therapy over AR-directed therapy. And just looking at individual cases, you can see if it was found the patients were resistant to an AR drug, but there were many patients who did not have AR-V7 present, again reinforcing that it was not the whole story. And similarly, you see when the AR-V7 is present, the results are independent of AR-V7 status. Now, one of the things that was important with this assay is that it did distinguish between the presence of the AR-V7 in the nucleus, where we would postulate it would signal. Outside of the nucleus, it would not. Again, you can see the frequencies are quite different, so this is just one variable that may be a difference depending on the assay that's used. And when we analyzed further, we were able to show that if you were looking specifically for the treatment interaction with taxanes over AR-directed drugs, if we consider both nuclear and non-nuclear, this interaction disappeared, but looking only at the nuclear factors, this relationship held. So we're currently in the process of trying to prospectively validate this, but right now the test is being run in a CLIA-certified laboratory in California and does have an approval, and it's under review for general approval as well. So we've shown that this marker will increase by line of treatment in the ability for it to be detected. We were able to show clinical utility by focusing directly on the decision points when we did our assays, and again showed that that tumors with AR-V7 present were resistant. Patients had a shorter time on treatment, shorter time to progression by radiographs, and shorter only our survival, but it is not the whole story. The treatment and specific interaction was shown for nuclear AR only, not for nuclear and non-nuclear. And there are 2 validation trials that have reached their accrual targets, which should be available shortly. So again, what I've tried to do is to give you a sense of how we deploy the drugs, how we consider management of the individual patient, depending on where they are in the natural history, how we've worked hard to align drug development with patient management. The real focus now is to identifying additional predictive markers which will enable us to inform a decision each time we have to change treatment, which means they have to be available quickly, and also discussed the ongoing results with AR-V7 as a predictive biomarker via a liquid biopsy for prostate cancer management. Just like to thank our team, and I'm open to questions, unless we're doing these at the end.